Hi, I'm Kimberly. I'm one of the nurse practitioners at Children's Health or UT Southwestern in Dallas. Oops, it's not on. Yep.
Hi, I'm Jenny Brend. I'm a parent from Stanford Children's Health, and I'm the Single Ventricle Family Advisory Council co-lead.
Hi, I'm Brittany Manning with Children's Health in Dallas, Texas. I'm the parent lead for our Family Advisory Council.
And I'm Tammy Shepard. I'm from Primary Children's in Utah, and I'm on the MPC Community Building.
Okay, like I said, I'm Kimberly Moore, and I'm one of the nurse practitioners at Children's Health in Dallas and an employee of UT Southwestern. I split my time between the cardiac intensive care unit and co-lead our interstage monitoring program. In addition, I'm the medical lead for our Family Advisory Council, and I'm really honored to be part of this panel today. Here are our learning objectives, like we always need to have. And then when I was first asked to be part of this panel, I thought to myself, I'm the science and math gal of the group. What data am I going to show that's going to be interesting? What information can I share that's going to be different? How can I convince everyone in the group to start or reinvigorate their hospital's Family Advisory Council? So I started and did a literature search of literature over the last 1 to 3 years. And these are some of the articles I found. I'm not going to do a dissertation and explain all of the articles to you, but I just wanted to start off with looking at some of the data points from the articles. A survey that was completed in 2021 was published in December of 2022, indicated that the number of hospitals across the United States with a Family Advisory Council is down to 51%. 61% of non-for-profit hospitals have a Family Advisory Council in comparison to 32% of investor-owned or for-profit hospitals have a Family Advisory Council. There is also a wide disparity across the United States. Several states report as low as 23% of the hospitals having a Family Advisory Council in comparison to Massachusetts. Massachusetts has the Massachusetts Care of All Act, and it's a consumer advocacy organization that requires all hospitals in the state to have a Family Advisory Council. Other highlights from the articles include the Parents Engagement Research article, that one article the author quoted as the triple aim of parent-centered care: to improve the patient experience by including quality and satisfaction, improve the health of patient population, and reduce the per capita cost of healthcare. The Child and Family-Centered Care Matrix places the child and the family at the center of the healthcare. The core components of this model include dignity and respect, information sharing, communication, and participation. The parental perception of Family Advisory Council revealed 4 different themes, including payback, personal invitation, a safe and equal atmosphere of sharing, and caring, healing, and sharing. After undergoing a prolonged hospital course, many patients and parents express a need to pay back, give back to the healthcare community in which they've had such a long time participating in. Again, this is just a brief literature search to kind of make my scientific heart happy, but there's so much more than just data. So about 3 months ago, our Heart Center Family Advisory Council was asked to consult on a project regarding signage for a DNR in the pulmonary unit. Our group was asked, because we have older patients, typically school age and adolescents who are neurologically intact. The basis of the project was to provide signs outside the patient's room to indicate code status, in particular a partial DNR and a full DNR. The overall goal of the project was to improve communication among providers. As a provider, I appreciated this very much. How could you go wrong with improving communication? I was even puzzled as to why we were asked to consult on this project. One day I asked Brittany, and her first response to me was, Kimberly, how would you feel if you were a patient and every day you had to walk past that sign? Yes, you made a very difficult decision, but then had to be reminded of it every single day you entered that room. How would you feel? And I stopped dead in my tracks, and I was like, wow, this is the why. This is why we ask parents to be involved. You see, it never crossed my mind. I was too focused on the signs, the communication, the process improvement. I never stopped to think about how you would feel if you were that parent. Continuing on, the family advisory councils ensure Care is centered on goals important to not only providers, but families as well. Equality and diversity are vital. Every person coming to the table has a different story of how they got there and what their journey will look like. Our Family Advisory Council personally is struggling with this topic, but we understand the importance of it, are working to kind of break down the barriers as we can. Like the story I said, patients and parents have a unique opportunity to fill in the gaps and identify barriers in which we don't always see.
Thank you, Kimberly. Myself and Jenny and Tammy are going to share with you, answer a few of these questions, just to give you a little context of our involvement in our family advisory councils. We are going to share with you some things that we're really proud of, and not as an in-your-face brag, but more of a humble brag, and more of hopefully some inspiration and some encouragement for you guys to go forth and practice or get your foot in the door with your family advisory councils to make a difference across your heart centers. So I'll start. Again, I'm Brittany Manning from Dallas. And my daughter Harper in 2019 was born with hypoplastic right heart syndrome and Charge syndrome, and later diagnosed with pulmonary vein stenosis. She's had a very difficult and long journey. Her first admission of a few was about 315 days. So we lived in the hospital for quite a long time. And despite all of the trauma and the tears, I felt a very strong pull towards staying connected with children's health in Dallas and staying involved. One day I was driving down to the hospital, and on a billboard on the Dallas North Tollway, which some of y'all probably don't know where that is, that's okay, was this billboard that said, "Go laugh in the places you've cried, change the narrative." And it hit me like a bolt of lightning. And that I've been struggling with our journey. We've been here for so long. We just really want to go home, but also feeling that juxtaposition of I have to stay involved, right? That became our new home. And I felt strongly to stay involved. And so thankfully, once we did finally get home and get home for good, after that, well, after COVID, the Family Advisory Council got started back up, and I jumped at the chance to be involved. Our social worker suggested that I also be involved, and so I just wasn't going to miss that chance, because while we did get home, it was such a culture shock to get home. We wanted nothing more than to get home. But once we got home, it was like, well, now what? All my friends are at Children's. I don't have any friends now except for our nurses, our social workers, the other moms that I met. I know nobody. That's my family now. So how can I get back there? I wasn't quite sure what our initial goals would be. I just knew that it was going to be important to get started. And what I'm most proud of. So I will have to say I need to go through these things because there are quite a few things that I am very proud of. First, we accomplished changing rounds and what rounds look like on the acute care unit. What used to be kind of dealer's choice with our providers, and some did walking rounds and some did conference room roundings. We felt very strongly as parents that everybody should be doing walking rounds to involve the parents and the caregivers in the decision-making and being part of the team. We felt like we were on the bench the whole time when we did conference room roundings, and it was just up to the nurses or the residents to fill us in later. That wasn't acceptable to us. And so as a Family Advisory Council, we worked with the providers on the unit and worked through a solution to change everything to walking rounds. Now there is no conference round, so we're proud of that. I'm proud of the community events and parties that we have held and been able to give back to the inpatient families and the staff. I'm proud of advocating for the hiring of another licensed psychologist dedicated solely to the Heart Center. I'm proud that we're currently partnering with the acute care unit and the CVICU leadership to standardize practices to implement care teams that benefit patients and staff. to provide consistency of care while listening and advocating for the staff. It's a partnership, and I'm really proud of that. But what I'm most proud of is the relationships and the community that we're forming. The projects done and goals met wouldn't have been achievable without that relationship and that human connection. I can tell that some of the walls that have the staff and parents have erected over time are probably due to some unfortunate bad experience. I can tell that some of those walls are coming down. I can tell because we're learning and we're growing and we're trusting each other. And that is going to have a lasting impact on the patients that come through these walls of our organization and yours, hopefully, for years to come. We have more to learn, and I'm here to share our experience, but I'm excited to learn from others and from you today as well. So with that, I'm going to welcome back to the podium Tammy to share her experience.
Okay, I shared a little bit earlier in my Ignite how I got involved, but I'm going to kind of dig a little deeper on it. Like I said, that I had received a letter in the mail that Primaries had sent out seeking parent partnership in their team that they were starting there at Primary Children's, and I jumped to the opportunity to be able to join them. And I specifically remember in my interview when they asked me why I wanted to be there. And I told them that I was so thankful for all that they had done for my son and for saving his life that I felt like this is the least I could do. And I'm still here because I still feel that way. This is the least I can do is help. And two, to help other families navigate their journeys so they're not as difficult as some of the experiences that we've had. So that's kind of my hope. But the other thing, I don't know what the questions were, but helping families have a better experience navigating is something that I just shared. But one of the things, or a couple of the things that I'm most proud of about our team is some of the projects that we brought home from here, that we gathered together and made them our own. And one of them was the pyramids that were shared here a few years ago for those kids that are in the cardiac care unit. And for those who may not know what they are, they're the pyramids that kind of help the parents stay involved in the care of their kids when they're in the ICU there. You know, I felt like those things were so important because it's not only for the children, but for the mental health of the parents, helping the parents to stay involved with their child while they're there, where they're not able to hold them those first few weeks, but then, you know what, here's something else you can do. And it just kind of tells you what level your child's at so that the parent knows, but can stay involved. And I was really proud of that. Another thing was our journey boards that we did. That was something that we brought from here, that we learned from here. And again, we took them home and made them our own. And that's when they're there in the ICU after their first, second surgeries, when they're there for a little while, the things that they have to accomplish before they can leave. Because as a parent, you're sitting there going, well, they're fine. Why am I not going home yet? Well, there's this, and this you need to do. And so it's just this cute journey board. And we've been able to make them ours there at Primaries, change them to where they work for our center and things like that. So I'm really proud of that. Another thing that I'm really super proud of that we've done there at Primaries is the symposiums that we've put together for the education of the patients, for the education of the parents, help get them involved, and also to teach and help them. And it kind of builds an even bigger community where more parents are like, hey, I want to get involved too. So I'm super proud of those things that we've done. And some things that I'd like to see our center do a little bit more of is, you know, now that we've accomplished a lot of the things that we have, there's always new things. I'm super excited about Vaughn and the program there, and I'm hoping that we can initiate a lot of fun things in that opportunity. We, as a group, have already been powwowing about a lot of the things and ideas that we have during our team time here, and a lot of exciting things that we're hoping to take home with us. But anyways, yes, those are the things. I do love more than anything being a part of our group at Primary Children's. It's opened so many doors for me, and it's kind of been my therapy. It's kind of been a great way for me to deal with a lot of the things that us heart moms deal with, and getting to be a part of that has been great. So anyways, I'll turn it to Jenny.
Hi, everybody. Again, I'm Jenny Bren. For those of you who don't know me yet, I'm a bit gung-ho and I'm a bit get started kind of attitude. I'm going to push one more slide over. Oh, that was two. I know I saw my slide in there. Okay, well, we're going to do mine without my slide. No big deal. I'm going to borrow this one now. There was a lovely picture. It had our team on it. I'm really lucky. I was actually, I came to an MPCQIC meeting at the same time while I was interviewing to be a part of our hospital-wide family advisory council. I did just get a ticket and show up here. This was 11 years ago. My son was just over a year of age at the time. And like other people had mentioned, I needed to give back. I needed to do something for the people that had given me my son, because we weren't sure we were going to bring him home. And here we are, we're home. I've got to do something in return. So I also wanted to help other families achieve great outcomes. We had a phenomenal outcome. How can I make it so that other people are going to get these good experiences back as well? And anything I can do or say that impacts a family in 10 years from now that I will never meet, I know my job is done. I know I've done something great. And kind of furthered the care of patients who I might not even ever get to come across. And that's the wonderful thing about this network is I get to hopefully influence patients in even other states, other countries. And it's a nice way of giving back, which is kind of, it feels great. We did partner with a champion provider, and I think that was a strength of our program is we had a provider who was also really excited about bringing families on board and noticing that a hospital-wide family advisory council was not enough. We needed more. We needed some things that were single ventricle specific, not just heart center specific, but single ventricle specific, because that journey is so unique to other patients that it was worthwhile carving out that time and that space within the heart center. Sorry, this is very difficult without slides. Who knew? After about a year of being involved with MPCQIC and the Hospital Family Advisory Council, we didn't end up opening a single ventricle family advisory specific. I'm most proud of the variety of voices and demographics at our table. We've worked really hard to give as many voices to our specific group as we can. We have dads, we have patients, we have families that speak more than one language. That definitely is something that we work really hard as a center to give. It also is a challenge to get that. Not everybody's as lucky as I am to be able to come in the middle of the day to a meeting. So I'm very proud of it, but it's also something that we continue to work towards. There it is. There's our team. We're amazing. I'm very proud of everybody in our team. I'm also really proud of the Single Ventricle Connection event series that we hosted during COVID. The webinars, the documents we've been able to do. There was actually no break within our meetings. We've been running these for almost 10 years now. We were due to host one 2 weeks after the pandemic began, and we just switched seamlessly. I think we did it over Zoom and it worked out great. And now we're continuing to host those meetings in that manner because we've actually learned as well from that. It is easier for our families to attend over Zoom. It's wonderful being in person, but we're getting a higher retention rate of the families who are able to be there because we're doing it over Zoom. We also now have a member of the Single Ventricle Family Advisory Council who is now also a dedicated parent mentor specifically for the single ventricle families. She works both inpatient and outpatient settings, and it's a phenomenal resource for everybody within the community. And it's really encouraging to go into a clinic myself and see something that we've worked on in the past and have it come through as part of regular patient care. So I'm very excited to share some of those notes with you guys, and thank you for bearing with me on my slides. see if the next one will advance for me. All right.
That is not the correct picture of the ladder, so I will wing it in some fashion, but that's okay. Oh, you just made them really large. Okay. Okay, so I'm going to thank you guys for all sharing. Sorry. We have, in true NBC QIC fashion, we have shared seamlessly and stolen shamelessly, although I may get that backwards. Did I get that backwards? Yes. Okay. The ladder of engagement. And so we split this into the provider ladder of engagement, and Jenny is going to present the parent ladder of engagement. So whatever side of the table you're on, you can kind of focus on where you can start. So level 1, you don't have a family advisory council. You're thinking about starting it, but it is so overwhelming. Personally, when we started thinking about our family advisory council, I struggled with being unsure if I was ready to hear the feedback. I'm a bit of a sensitive person, and so I didn't know if people were going to tell me all sorts of things and my feelings were going to get hurt and it would be a negative experience. So that was one of my very first fears. But however, we got past that and we were able to contact our hospital advisory council. So if you are working to start yours, contact your hospital, see if there's a main family advisory council. They were able to provide us with a charter to start, tips for recruiting, and they're currently still in charge of our vetting process. And level 2, you are making plans to have a family advisory council, but you haven't gotten all the way to starting one. The difficulties are you're trying to have a hard time identifying parents to contact to be part of this. Why don't you start with a small subset? Why don't you start with your single ventricle patients? Why don't you start with your transplants? It's kind of what we did at our center. Like I said, I work for the interstage monitoring program, and the social worker that I partnered with works for the transplant program. And so we kind of were able to pool our resources and identify families that we thought would be able to be involved. Troubleshooting diversity, Jenny has done a really good job of that. We continue to struggle with it, but we understand the importance of it. And having challenging conversations and making sure that the council is productive. And I think that that is really important. And Tammy has a few slides about the rules of engagement and how to kind of conduct yourself on the Family Advisory Council. Level 3, you have several parents who meet regularly, but you don't have a consistent large network of families. And action items to take for this partnership is creating flyers and QR signs that you can put in your clinics, that you can have parents can access information easily. And all of this should be in multiple languages. And last, if your center is at a level 4, you kind of have everything going on. There's always room for improvement. There's more people to reach. There's more events to have. How can you improve your diversity? How can you reach a patient population that you haven't had a chance to reach? Also, do you have more goals? Advertising yourself as a consult for patients, for projects who are across the Heart Center is always a good way as a level 4 to kind of go up. And also these ladders are fluid. It's not, you're stuck at level 1 and you're at level 3 and you can never get to level 1. We've definitely had meetings where I was like, that seems really not productive. We should probably go back to the drawing board and see what we need to do and see how can we change this. Likewise, we've also had meetings where I was like, wow, we accomplished a lot. We're doing a great job. And so they're all kind of up and down. And I think you will also provide you guys with handouts of the ladder of engagement. It's on one screen. It's very hard to see if you do that. Oh dear. Okay, there's your slide. And the last one I'm going to talk about is tips for engaging your administration. Providing evidence-based research, some of the articles that I pulled at the very start of this presentation. Bring an administrator to the planning table. I'm pretty confident if you include them in the ground up, especially if it works, which it will, they will be very happy about it. Also, you can talk about reducing the cost. And what administrator doesn't want to reduce cost? communicate the value of families and parents, and then provide the unique position and how that their stories have impacted the care and that they're being provided. Work together to change the culture. The culture has to be one that parents and patients should be part of the process of change. So it goes back to you.
Okay, so the providers have a plan, but we're going to make a plan for these patients and parents that are also in the room. Because sometimes that's what it's going to take, is it's going to take a family member or a patient walking into a hospital and saying, this is the time, we're going to start now. Because I think from hearing everybody, all of these great meetings today, everybody agrees that now is the time to start. If you have not already, and now is the time to improve for everybody. So these are the different levels that I've come up with. Again, as she mentioned, this is fluid. It can go back and forward, even depending from meeting to meeting. So there's different types of ways you can get people going here. But this is specifically for the patients and parents. But providers today also take these back. So as you're identifying family members and patients who can come into your groups, know that these are some of the things that they can work on also, and you can bring this to your councils. So there's 4 levels again. One is going to be our entry level. We've got individual contributors, we've got immersive contributors, and then co-production, which is what hopefully everybody's main goal is. At entry level, this parent or patient knows the hospital is working towards goals of improvements, but we don't know quite what those are yet. They might know another family through the hospital with a similar diagnosis, probably met them in the hallway somewhere or in the cafeteria. And they're able to discuss parts of their own experiences in a mostly cohesive way. We're able to have the conversation, my child has a single ventricle heart defect. As an individual contributor, they might be included already in these NPC-QIC, FON, or center discussions on an individual level. They're doing what I did, they gate crash the party. Providers might know that they can come to them and ask for feedback about their family's specific care. So this is not global care. This is in your personal experience. Can you tell me more about that? The parent or the patient is aware that families can have experiences different from their own, even within the same hospital network. So I know that my child's experience in clinic might look different from another child's. Even if they're in the same clinic day, it might look different. They're a great person to approach about doing work on a larger scale, including creating your new FAC or participation in one that you already have running. These are the people that hopefully you can pick out when you see them and say, I'd like to extend this offer. I'd like you to be a part of something bigger. As an immersive contributor, they're attending local center meetings. They're either in person, they're in Zoom, they're doing this hybrid approach, whatever's working for you at that time. You're hopefully able to attend some action period or other network meetings. Maybe not every single one, but your goal is to be trying to get to some of those. You're able to think of patient groups as a whole, not just your personal experience. So now I'm hoping to think not just about what happened to me, but maybe what happened to other preteen Fontan patients. Let me think about those kids as well. We're confident sharing our personal story, and you're able to adjust the narrative to highlight points within the specific ask of the discussion. If somebody's coming with an FAC topic about feeding, I can narrow down that conversation to only think about the parts of our journey that encourage feeding conversations. I'm not going to hopefully go down a huge rabbit hole and divert to something else. And then co-production is producing center work with teams, including setting the agendas for the meetings. This is not only provider driven. The parents have a voice at that table for setting the agendas. We're starting to learn about QI efforts and research from a systems perspective. We're finding ways to become involved at the hospital and national level. We can speak to a variety of demographics and experiences, even if they're not our own. For example, I'd like to think about a family that maybe doesn't speak the same language as myself when we're having these meetings. Even if their voice is not represented at our table, I've still got to make sure I'm thinking about that group as well. And how does this look? We need to make sure we translate this document. We're also working on discussing more emotional and challenging aspects of care, having the real hard conversations. This is where this is going to come up. In our particular group, we encourage families to know they can step away at any point, no questions asked. And if they're having a hard minute, as the lead for the group, I'll circle back to them and say, hey, do you want to debrief? Do you want to talk about that? Yes or no, you don't have to, no pressure, but know that I'm able to have that conversation with them in a one-on-one setting instead of in the group setting. And then they can rejoin the group whenever they're ready to. And hopefully you're able to give neutral, constructive feedback in a variety of settings. We're not having an FAC to rail on our bad experiences. That's nobody's intention. We want to make this a positive experience. Everybody has the same goal of making better care. But sometimes hard discussions need to be had of, hey, this could be done better. And we're going to have this hard conversation and everybody's going to come out of it better with positive intentions. And I think that's really important to kind of take back from this is a parent is not going to be doing this and putting all this effort in if they didn't want to make it better for somebody else. And so I think that's really important for there. And again, you can co-produce a meeting and then go back and be like, okay, well, I really needed to go. I went back one step and that was more of an individual contributor meeting. We can be fluid, but hopefully everybody's able to identify themselves of where you're at right now and what we can be working towards in the future. And I'm going to tag out again.
Okay, so I'm going to cover some of the barriers that you might find when you're getting your community building. And some of them are communication challenges. So like Jeannie had mentioned, maybe some family members that don't speak the language, but we want their voices heard. There's going to be some challenges that way. And also maybe rural areas, things like that. Those are going to be some complications you might have. Limited resources. I know this is a huge one, and I know this is something that we hear all the time, that your resources are limited, but keep begging. Hopefully. Medical culture. That's one that we can have. HIPAA concerns. I know at primaries, when I came on, they made me take a little course that I had to do before I could volunteer there and before I could do the things. Those are some steps that you'll want to do. Hopefully you have some of those in your center. And then just the differences that we have. The next one that we have. So this is a contract that we send out at Primary Children's after they've gone through the interview process and when they've been chosen to be a part of the team. And it just kind of goes over what I love the most about it is kind of gives our insight and our goals, which is just to better meet the needs of the families. And that's the main goal. And then it kind of lists the things that the requirements that when I say we as a team have for these parents to be involved, for the parents to be involved so that we can meet that goal, which is to better help the needs of the families. So a couple of them Jeannie had already mentioned, but I think it's worth mentioning again. I'm not going to go through every single one of them because of time, but one of them is comfortable in speaking in groups of candor. I really feel like this one is really important because that's really what we should be looking for when we're looking for parents to become involved, that they can see outside their own story, their own involvement, their own experiences, and be able to see experiences of others. We want to hear about the hard stuff. We want you to be able to talk about the hard stuff because that's what's going to help us set goals and achieve them. And we don't want a parent that's going to tell us what they think we want to hear. We want them to be honest and if they don't agree or if they agree, because that's how we'd be able to get them. A couple other ones that we have on there are about our experiences, are using our experiences constructively, different things like that. several of the, or using these in our own perspective to indicate change. Because without we can make change, right? And because not all stories are the same. So, but we do have this where it would be available for you guys if it's something that you're needing to kind of construct your own for your center. And we hope that you guys can use it, but it should be available to you after.
Okay. Y'all are doing a great job. It's 4:30. We've all been here all day. I've got Hamilton tickets later. Does anybody else go into Hamilton? But we want to make this practical for you. We want you to walk away with something that makes sense for you and your organization or your hospital. So we've got a little exercise for you to do at your table with your group. You've heard all day and hopefully, likely you've bought in to the fact that patient, caregiver, staff relationships are so very important to patient outcomes. And so we have this worksheet, I guess we'll say. I'm a former teacher, so that's all I know this as a worksheet or graphic organizer, however you want to say. But at your table, we want you to go through this. Start on the left. We've heard about the ladders of engagement. Start on the left. Where are you right now? Okay. And then jump into the middle, if you will. If you want to do this progression, jump into the middle with the why. Why are you doing this? What happens if we don't do this? And why should we do it now? You also have some time, or over on the very right, to discuss at your tables and brainstorm where you want to be in your future state. Maybe you're at the ladder rung 1 right now, and we just need to get to 2. We're all data people here, so we know, as we've said, it's fluid. We can go up and down, but what's the trend? Okay, if we want to trend, we want to trend up. So maybe you're at a 2 and you want to trend up to a 3. So what are some of those 30-day goals, 60-day goals, 90-day goals that you want to get down on paper and share with your group so that you guys can be held accountable with each other to get there? And then everything else in the middle is the how and the what. So we know why we want to do what we do. We start with why. Thank you, Simon Sinek, for giving us that. Find your why and start with why. But start with your why and then fill in the how and the what. What are some of the challenges that we have? What are some of the strengths that we have? Who are some of my champions that I can pull in here? Parents and staff. What is our mission statement with our organization? Because that would be something that we could closely attach ourselves to then go to our administrative team to get that more buy-in, to say, hey, you know, the mission at Children's is make life better for children. That's easy enough, right? But here's how we're going to do that, because we're going to improve patient care across the continuum by partnering with our parents and our families who have the best insight into these children that we want to make life better for. So get that down, write down some of your values as a group, and just find some clarity in the way you guys are communicate. This is just a brainstorming tool for you that we're going to give you some time right now to work on as a group. And then we hope you can walk away. You don't have to finish it. Maybe you won't, because we can only give you about 10 minutes or so, because we want to save some time for questions. But we want you to walk away with something tangible and powerful that you guys can take back to your organizations and do. Providers and parents and patients alike can brainstorm on this. So we're going to give you a little time to do that. And right? Go.
We can walk around. I'm not doing walk around. Adrian. We should walk around.
Okay, you
but
can
I'm
take the
just
front
shy.
tables then.
Okay, I'll walk around to my front.
Thank you for
table.
having those, by the way, on the table, because I was like, that's great.
That I like.
It was
submitted them
there.
in order.
You did.
It was like,
I thought we went to.
not four. Okay, that was perfect. I'm really sorry about that.
Stumbling on my words. I feel so stupid. It sounded as awful as I felt like it. No, it was great. I'm sorry, but I would get those words and I'm not trying to figure it out right now. And I'm like, like I froze. I froze because I'm like,
What was it called? And I was like, oh my gosh.
I feel like I read my text. I saw them in front of me and then read them again and I was like, what was I doing? She'd figure an idiot. She thought, what's wrong with this? And I was like, oh god.
That word and that word, I was like, I was like,
Okay, let's go. Those are. Go get those worksheets done. Let's see, hold in the back. I know, it's too big.
So I said,
right?
No.
You said Jean. Oh.
Okay, so I'm a big fat liar and said we had more time than we actually do. So I'm gonna bring you guys back if you don't mind. I really hope that that gave you a little something to go with. I'd love to see maybe a show of hands of how many people out here or how many organizations do have standing family advisory councils that you lean into. I want to celebrate that. I want to celebrate that. Thank you. So please continue this. Likely you didn't have time to really dive in to make it extremely meaningful for you guys, but please take this and continue your brainstorming with your organization so that you guys can build these family advisory councils and lean into them, or a youth advisory board. That's something that we had at our organization that we don't have at this time. Maybe Kim can make me a liar, but no. Okay, darn. A youth advisory council, hospital-wide or, it's heart center specific. But in closing, I do want to leave a few minutes for questions if you have any. I know we don't have much time, but just very quickly remember, right? This ladder is fluid. Think of the trend. Focus on positive solutions-based. If you can build that culture from the very beginning and find those parent champions who are going to stand with you and focus on solutions-based conversations and not the venting sessions, as Jenny had mentioned. Zig Ziglar said, you don't have to be great to start, but you have to start to be great. And so I just want to encourage you guys to get started, right? Just cultivate meaningful, authentic relationships with your parents and your partnerships. And I couldn't have said it any better this morning with Tammy had said, it's a little awkward. We're all out on the field playing baseball together at first, but we need to all get on the field and play. And I loved that so very much. So to quote the great Tammy Shepard, let's get out on the field and play. And I know we have like 2 minutes, but what questions can we answer for you at this time?
Hey there, great presentation, y'all. We did have a couple questions. We were talking about it at our table, and we were curious for those on the panel, how many members do you feel is the right quantity to really get the work forward and not have too many cooks in the kitchen? And what have you guys found?
At primaries, we have 2 parents at all times, but then we have like 1 leaving and 1 coming in. So there's like 3 at a time, right? Yeah, about 3.
At Stanford, we have 7 currently. My goal is 10. Again, we fluctuate in and out. Our kids are in and out of the hospital. Families have things come up. So I think 10 would be a good number to start with. That way, again, if somebody can't make a meeting, it's not a big deal. You still have a good resounding voice.
I would agree with 10. We started with, I think, 7 or 8, and we've, some have trickled out when we're recruiting more. But 10, I think, gives you that great balance. As long as you, please keep in mind, the diversity of unfortunately, the diversity of our family advisory council is not representative of the diversity of our parent or our patient population. And we are aware, and we are trying to recruit heavily to make sure that we get some parents involved that do represent the patient population more accurately. But I think 10 gives you that great number to handle absences, to handle vacations, to handle different perspectives, but also not have, as you put it, too many cooks in the kitchen, because we're human beings and sometimes that can make things difficult.
Just going to add one more thing. Our Family Advisory Council made a conscious decision to only invite families after about 4 to 6 months post-Glenn. There's too much going on in the beginning. we felt that that was just something they needed to be with their families during that early time. And then after that, they were able to distance themselves a bit more and come and provide valuable input after that.
Do your teams meet virtually or in person? And how have you, how has that impacted the quality of feedback and engagement?
We hold a standing virtual meeting every month on a Monday at 1 o'clock. So, and that's what we've kept every month. But we do like to meet in person once in a while. But COVID kind of put a kink in that. We haven't gone back to in person yet, but we're going to start to.
We meet in person. We meet in person once a month. And I'm that type of in-person person. I think we have great conversation. I think Zoom is a great tool. For us personally, it makes it a little bit difficult to really get in and engage and sometimes have some conflict. So we've been meeting in person for 2 years now, and that's worked really well for us.
And we met for 7 years in person monthly. And then after the pandemic started, we actually hosted our first Zoom meeting a week into the pandemic. So we had no pause for that, which I'm pretty excited about. And then we would like to get back to in-person meetings. I think we're having some conversations within the department about maybe doing quarterly in-person meetings. And then still giving the opportunity for Zoom. The issue we have out in California is a lot of our families are not coming from within 10 or 15 minutes of their surgical center. I personally drive over an hour just to get to a meeting, have the meeting for an hour, and then walk back to my car, drive back for an hour. It's half a day out sometimes, which is difficult, especially for families who are taking time off from work. They've got multiple childcare needs. So for us right now, Zoom is a nice option, but I would like to get back to a hybrid choice.
See, and that's the same for me. I'm 2 hours out. So for us, it's nice to do virtual. It makes more opportunity for other families that otherwise wouldn't be able to be involved.
Yeah, that was a lot of my question, which is partly about the transportation and the distance piece, which you've kind of addressed. And I guess every center has to figure out who's part of theirs and how they're going to prioritize that. But the other thing that we've struggled with is the timing. So have you found more success with trying to meet during the day and hoping that people who are working can take a lunch break? Or do you do it after hours when it's harder for the clinicians? What's been working well for you?
We hold our meetings Monday evenings from 6 to 8 once a month. We do offer a virtual option. There's always a Zoom link. The primary is in person, but there's always a Zoom link to join virtually if for childcare reasons or transportation. We have not tried during the day. I wouldn't be able to attend during the day. I do work. And so that would exclude me, and that would be a big bummer. So we do now. Childcare is the other thing, right? That's dinner time. But I think what we've all worked out is we can have a virtual option, or somebody else can come take care of the kiddos, or, it's once a month, and our group handles it really well.
A lot of our clinicians we have a big group that work there at the hospital. I think that's why 1 o'clock works best for our center, because it's lunchtime. So
our sweet spot has been 11:30 to 1. If you feed them lunch, they will come. It worked really well for a number of years. And then now we've kept the same because the people that are working full time outside of the hospital, they're able to take a lunch break. I do have one family that comes in from 12 to 1, and that works out just fine. We make sure that if she has something particular she wants to discuss on the agenda, we make sure we just shift it to the last half of the agenda so that she's able to be a part of that. Or if I know that there's something that we're discussing that I know the members there, I'm like, okay, I'm just going to put that at the end because I know this person's going to have a really interesting perspective on it.
To throw it back to the whole point, probably ask, right? Ask your families and put it out there. When you put the feelers out there for who wants to join, the all call, come join us, come sit at the table with us. What works for you? And it's different across the table here, and it's likely going to be different for you guys. But I would ask that question first and foremost. We're getting the hook. So we're going to exit, right? Thank you guys so much. We wish we could take some more questions.
Quick question. Yeah.
Thank you guys so much. Do we want to do one final question? Okay, great.
Or was this like a broader hospital family advisory board that then went down to the center, then became a smaller?
Was it a broad hospital advisory board to start and then went down to single ventricle, or was it just single ventricle to start?
So we have a full hospital-wide family advisory network that is separate from what we are. We are the Heart Center Family Advisory Council. We are not single ventricle specific. Technically, however, all the parents well, not all, that's not true. One of them was cardiomyopathy. So most of the parents happen to be single ventricle parents, but that's not by design.
Ours is called the high risk because it's just the patients that are, at the higher risk, but those are the parents that are mostly involved, but
And our center was a hospital-wide family advisory council. We developed a single ventricle family advisory council. And then because of the benefit of that, it's actually now expanded back out into the heart center as a whole. So now we run single ventricle and a heart center one. And there's 13 different service lines within our hospital now. We have different, specialties that come. And each of those have a lead as a parent that pairs with some providers. And we have similar councils running throughout the hospital now.
No, you guys are great. Thank you so much. And thanks everyone for your amazing questions and discussion.